we will cover off what we think is the current state of the literature and then open it out for discussion. So on that note, Nicole, I'm going to hand over to you and we'll go from there.
Thanks, Kaz, for the kind introduction. So as Kaz mentioned, my name's Nikhil. I'm an antimicrobial stewardship pharmacist here at Peter Mac, as well as a research fellow with the NCIC. And today I'll be discussing quinolone prophylaxis in neutropenic fever, exploring both the pros and cons of this fairly contentious topic. So as Kaz mentioned, we'll kick off by using the Mentimeter and going over a case. So we have a 54-year-old female who is admitted to your hospital with a relapse of AML and is about to begin an induction therapy with FLAG-IDA. Her previous history with regards to her AML, she a couple of years ago had a core binding factor AML for which she received 7 and 3 induction. Her induction was complicated with very severe mucositis and an ICU admission for septic shock. She was able to go into admission, and then that was followed up with 3 cycles of HIDAC. But unfortunately, a couple of years on has now relapsed and represented. At your hospital, your local antibiogram indicates that you've got 25% resistance to quinolones in your E. coli, and the hematology team have come to you and asked you if you would recommend fluoroquinolone prophylaxis when this patient is undergoing induction. So you can see the Menti code in the top right there, and it's also in the chat. So what I might do is actually just jump into it and see what people's results are. So I'll give that a bit of time. It seems some overwhelming no's here. Might give that another 15 seconds or so. Then you're going to be, I'm just wondering if there's going to be any brave souls that are going to go for another answer. Okay, great. Looks like we have consensus pretty much. We can end the talk right there, essentially. No, we'll go through maybe some of these pros and cons, and maybe we'll re-poll everyone at the end and see where everyone lands. So before we do that, I thought we'll go into some background, and to do that, I've made a timeline here of hematology treatments starting from 1960 to the present day. Seeing a timeline like this can give us an appreciation of the accelerating pace in which the cancer landscape is changing. Prior to 1960, leukemia was treated with single-agent chemo, and after that, multi-agent chemo was introduced and improved remission rates and outcomes. But even back then, it was well recognized that infection-related mortality was a major issue. And there's this one 10-year study from 1954 to 1963 found that infection was a major cause of death in 70% of patients with acute leukemia. Since then, there's been an acceleration in breakthroughs in treatments in this space with the introduction of a new standard of care in 7+3 in AML, in the introduction of bone marrow transplants, cranial irradiation, and then in 2001, imatinib ushering in the era of targeted therapies. And since then, in the last 5 years, we've seen just an explosion of new treatments, whether they be cellular therapies like CAR-T, bispecific antibodies, or small molecule inhibitors or other targeted therapies. But we should recognize that not only has there been progress in cancer therapies, but also improvements in how we detect and manage infection and sepsis. And remarkably, even in this study here, this 10-year study, they found that fatal staph infections fell from 23.5% to just 3% by the end of that study, really showing that improvements have been made in this area too. But Be that as it may, one thing that has remained consistent since then is that infections in cancer patients are still a major issue. Cancer patients are quoted to have at least 3 times the risk of infection compared to the general population. And in one study in allo transplant recipients in Australia, infection-related mortality remained the most common cause of death at day 100. So if we go into a little bit about the history again of neutropenic fever prophylaxis itself, how did we actually land on fluoroquinolones being the treatment of choice? So early methods of infection prevention really relied on protective isolation and gut decontamination. So here's an image of a paper published in 1973 that shows what protective isolation looked like. And here's a table from that same study that showed you what antimicrobial prophylaxis regimens look like. So you could see patients received 6 hourly oral non-absorbable antibiotics like vancomycin and gentamicin. They had to do mouth washes and throat sprays and apply nasal antibiotic ointments. So as you can see, it was quite arduous, but it did result in decreases in infection rates. And the other issue was that it was just generally poorly tolerated. So this led people to look towards maybe moving towards using absorbable antimicrobials as neutropenic fever prophylaxis. And the first studies that were done with Bactrim, which found similar or better efficacy in terms of infection prevention compared to gut decontamination. But more importantly, it was actually just better tolerated and easier to do. Over time, there were signals of hematologic toxicity with Bactrim, as we are all well aware now, with prolonged recovery of cytopenias. So this is what actually led people to study other antibiotics, in particular fluoroquinolones. And you can see here that fluoroquinolones in a pooled analysis resulted in a larger decrease in mortality than Bactrim, and more importantly, well, just as importantly, didn't result in the cytopenias that Bactrim did. And that's really how we got to where we are now, with fluoroquinolones being the main drugs used here, in particular ciprofloxacin and levofloxacin. So here's the current state of play, so to speak, when it comes to this pro-con debate. On the left side, we have the pro side, who are adamant that fluoroquinolones reduce bloodstream infections and therefore reduce associated morbidity and healthcare costs. On the other side, on the right, we have the con side, who claim that fluoroquinolones are not benign medicines by any means, and we have an increased understanding of alterations of the microbiome impacting outcomes in hematology patients. And then lastly, using these antibiotics in such a manner will increase resistance rates and then put us will potentially reverse these benefits that we currently see in terms of infection prevention and healthcare costs. But you see there's one missing piece from this argument, and that's the holy grail, mortality, who's sort of sitting in between both of them, not quite sure which way they're going to go. So you would hope that with all this arguing back and forth, that guidelines would be able to provide clear direction on what to do, seeing as that all these expert groups are looking at the same, if not similar, evidence. But that seems to be far from the case. So you can see in this table here that there are many guidelines available. Some are over a decade old, including the Australian ones, which are currently being updated, as Kaz mentioned. But then you have guidelines that are updated or published just this year. So you can see that guideline recommendations are quite different. So for example, the Australian guidelines and the European ECIL pediatric guidelines recommend against fluoroquinolone prophylaxis, whereas your NICE guidelines from the UK or your ASCO guidelines from the USA do recommend fluoroquinolone prophylaxis. And if you look at some of these other ones, they kind of sit on a fence a little bit more, with weaker recommendations to consider fluoroquinolone prophylaxis in either intermediate and high-risk groups or just high-risk groups. On this, as a side note, it should be noted that these guidelines have used variable methodologies. Some have only looked at RCTs, while some have looked at RCTs and observational studies, and all of them, well, most of them used different grading systems as well, which makes interpretation of them a little bit complicated. So if we look at febrile episodes and bloodstream infections in isolation, what we can say is that a consistent benefit has been observed across both RCTs and observational studies in adults and the pediatric population. So if we look at relative risk reductions for febrile episodes, we can see in adults that multiple studies have shown a relative risk reduction of 24 to 29%. Whereas in pediatrics, this outcome is less often measured, but one study did find a 13% reduction. If we look at bloodstream infection, relative risk reductions across adults and peds are pretty similar, with 40 to 46% in adults and between 37 and 50% in the pediatric space. So here's a forest plot from a 2018 meta-analysis by Egan et al. That looked at adult and pediatric RCTs. The figure reports bacteremia rates of studies that compared fluoroquinolones to either placebo or gut decontamination. And you can see if the risk ratio falls to the left, it favors fluoroquinolones. And for most studies, they did fall to the left. And when these studies were combined in this meta-analysis, there was a risk reduction of about 44% in bloodstream infection, which was statistically significant. What about systematic reviews that look at just the pediatric population? So here's one that was done in 2022. And you can see in this forest plot that looked at children with acute leukemia, that again, there was a significant reduction in bloodstream infections. And notably, this systematic review included observational studies as well as randomized controlled trials. But what I found interesting was that when they looked at stem cell transplant recipients, or pediatric stem cell transplant recipients, there wasn't a statistically significant reduction in bloodstream infections. And this is curious, I guess, because we traditionally really consider allo transplant recipients to be amongst the highest risk for complications in neutropenic fever. But this also, I guess, explains some of the recommendations that we see in these previous guidelines. For example, in 2020 from this international panel, which recommended to use quinolone prophylaxis just in acute leukemia patients that had AML or relapsed ALL. So they did not include allo transplants in that recommendation. So moving on to morbidity, we should stop and recognize, I guess, that infections carry a physical, mental, and emotional burden on patients. Discrete choice experiments, one by Sung et al. And one by Regier et al. Have shown that prevention of infection is valued by patients and caregivers alike. Another study by Rabinu et al. Observed that infection events increase stress on patients and families. So an argument could be made that prophylaxis can reduce incidence of infection and also relieve some of these treatment-related burden for patients. In addition, we shouldn't forget that the impact of infective episodes are not all just short-term, and there are long-term ones too. Post-sepsis syndromes have been described in the general population where patients can suffer impairments in physical, emotional, or cognitive domains for even months following sepsis. And these concerns are particularly relevant in the pediatric cohort, as one study's found that bacteremic episodes in children are associated with an increased risk of osteonecrosis, which can be quite disabling. Another study found that in children that had bacterial bloodstream infection, they were more likely to have neurocognitive function deficits at even up to 5 years after treatment completion. So notably, while these studies may have some limitations being observational and not particularly controlling for all confounders, And the other limitation being that none of these studies actually look at whether or not fluoroquinolone prophylaxis reduces the incidence of these issues. It still should give us some pause to think about these concerns when it comes to preventing infections in patients who are neutropenic. So with regards to costs, it should come as no surprise that infections in the cancer cohort result in increased healthcare costs, and some studies have certainly tried to quantify this. So one study in America looked at infections in allotransplant recipients, finding that there was a excess cost associated with this of up to $17,000. Another two studies looked at catheter-associated infections or central line associated infections in pediatric and adult patients in the US, and found that excess cost of $45,000 to $69,000 was observed. And then with some Australian data in terms of the cost of febrile neutropenia hospitalizations, the median cost of a solid tumor patient was about $8,300, whereas median cost for a hematology patient was up to about $22,000. So there certainly are costs associated with infections in this cohort. But the question really remains is, have studies been done to show that fluoroquinolone prophylaxis is cost effective? And there have been some studies in this space, which I won't go into too much detail in, but two of them were done in the pediatric cohort and concluded that fluoroquinolone prophylaxis is cost effective, whereas one study in an adult demographic in allotransplant recipients found that fluoroquinolone prophylaxis wasn't necessarily cost effective. So probably time that we address the elephant in the room, so to speak, and that is mortality. So we could start by looking at some of the systematic reviews that have been done. So there's this systematic review done by Gavilli et al., which looked at studies from about 1973 to 2006. And they concluded that antibiotic prophylaxis, but especially fluoroquinolone prophylaxis, was associated with a reduction in mortality. But some things I think to note from this particular review is that, one, they included some really quite old studies where the comparator arms had probably higher rates of mortality than what we would expect now. And also including old studies doesn't really account for the fact that we've probably got improved management of patients with neutropenic fever and sepsis as well. And if you look a bit deeper into some of the studies that they included, some of them had methodological flaws and were quite small and had really large effect sizes, which we wouldn't really expect to see, I think, in modern day studies. So that could have influenced the results too. So subsequent systematic reviews haven't really made that same conclusion. So one was done by Michalska et al., which looked at both RCTs and observational studies from 2006 onwards, and they concluded there was no difference. And another meta-analysis, which I touched on earlier, by Egan et al., found no difference in overall mortality, but a reduction in infection-related mortality. And then a systematic review in pediatric patients published just last year found that the data was too heterogeneous to draw any conclusions. So I thought I would also just touch on the RCTs that have looked at this from about 2005 onwards. There have been other RCTs that I haven't listed in this table, but that's because they're a lot smaller than these ones. These ones are a bit more robust, so I'm just going to limit my discussion to these ones. So the first one is a study by Buccaneve et al. in Italy, and this was done in acute leukemias and transplant recipients. And this study found that there was no difference in mortality, though there was a trend towards improvements. It did not reach statistical significance. Then there's a study by Cullen et al. In 2005, and this was largely in solid tumor patients, so not our higher risk patients, but they didn't report mortality outcomes. Then there's a pediatric study by Alexander et al. Looking at AML patients and transplant recipients. And they found no deaths due to bacterial infection in either arm. And then we've got this study by Drayson et al. In adult myeloma patients, which do you find a reduction in a composite outcome of first febrile episode or death? And I think that's a very interesting composite outcome to have, combining something like first febrile episode and death, probably not considered to be of the same severity. But if we look at this Kaplan-Meier curve, I'll be interested to see what some people on this call think about it. But my thoughts were, it was interesting to see such early separation between the two groups within 1 week with this primary outcome. It really makes me think that it's largely driven by febrile episodes and probably not death, and that the follow-up of 12 weeks probably isn't that long in myeloma patients, because this is really considered a chronic condition and patients live for quite some time with myeloma. So it is good that this study actually did follow patients up for a bit longer, up to 12 months. And you can see in a supplementary where we find all the good information, that the overall mortality actually evened out by 12 months. And reasons for that have been postulated, in particular by a couple of authors that are pretty well known to Peter Mac. So Ben Ter and colleagues commented on this, thinking or postulating that it could be this increase in mortality after 12 weeks in the lever may be attributed to microbiome changes that might have altered treatment responses to myeloma therapy. So I thought I would make a slide to just formally touch on the limitations of all this data that I've already touched on, because I think it's really important to think about to have these considerations in mind when we interpret data from these RCTs and systematic reviews. So I've touched on some of these things, but I'll just go through it again. So I think it's important to look at the date of the studies that are being conducted. A lot of these systematic reviews include quite old studies, and even some of these RCTs you could consider quite dated now. 2005 is almost 20 years ago. And since then, we know that all these variables are changing and shifting that affect infection-related mortality. We know that cancer patients are getting older due to improved survival. Cancer therapies are changing. We're using less probably chemotherapy and moving towards targeted therapies, and that might influence depth and duration of neutropenia. In some cases, we're actually adding targeted therapies to existing chemo, so that could actually worsen immunosuppression. And then over time, we're getting better at implementing infection prevention strategies, sepsis detection and management, and also improvements in diagnostic with things like imaging and microbiological techniques. And then you've got antimicrobial resistance. And I think that's one thing that's, again, the elephant in the room in a way, because a lot of these studies don't actually report what their baseline resistance was. RCTs are not really well designed to capture epidemiological data, so we aren't really capturing very well the impact on AMR from these RCT interventional studies as well. And then when we look at these systematic reviews, we just really need to think about whether or not they included observational studies, as it is recommended to do so, as it is thought that they improve your inferences. And you need to look at the timeframes in which the studies were included, which I've talked about why that's important just now. So if we move on to adverse effects, it's well recognized that fluoroquinolones have quite a few adverse effects associated with them. In fact, there are FDA boxed warnings about tendinitis, aortopathies, musculoskeletal complications, neuropathies, and QT prolongation. So with tendinitis and aortopathies, fluoroquinolones do this by causing tenocytotoxicity, which results in a decrease in collagen production. But independent of this, they actually also increase the destruction of collagen, which results in structures such as your tendons and aorta to become compromised and puts people at risk of these issues. So some risk factors that can accelerate this increased age and corticosteroids. And we know that a lot of, for example, our AML patients are older, so there's a risk factor for them. And a lot of ALL patients receive lots of corticosteroids, which is another risk factor. And then we've got musculoskeletal complications, and this is really mainly a concern for our pediatric population as they have developing bone, cartilage, and tendons. which may be adversely impacted by fluoroquinolones. And a similar thing with neuropathies that can be caused by fluoroquinolones. It's biggest concern is in the young population of ALL patients who receive a lot of vincristine, which can cause neuropathies, and potentially you're adding fluoroquinolones to the mix and accelerating or increasing the chances of that occurring. And then lastly, we've got QT prolongation. And it is less of an issue with Levo and Cipro than it is for Moxie, but it is still something to keep in mind because, again, a lot of our acute leukemia and BMT patients receive induction chemotherapy, get severe mucositis, develop electrolyte abnormalities. They're already on other drugs that prolong the QTs, such as azole and antiemetics, and then adding fluoroquinolones may put them at unnecessary risk of some serious adverse events like Torsades de Pointes. So I guess the question now becomes, have studies actually looked at this in the population of interest, being the cancer cohort? And the answer is yes, there have been some RCTs and observational studies that looked at things like tendinitis, neuropathies, and QT prolongation. And none of them found a difference. So I guess you could argue that these adverse effects may not be as big of an issue as some might think. But then on the other hand, you could argue that maybe this is falsely reassuring because we know adverse effects are better established using population level data. And we've already established these as issues using population level data. So with regards to C. diff infection, so we know that C. diff can be life-threatening. It's associated with healthcare costs, treatment delays, and has a high rate of recurrence. So therefore is a key consideration in this argument. So although in the general population, quinolones have been associated with C. diff, data in the neutropenic cancer cohort is actually much less clear. So contrary to what most would assume, some studies have actually observed less C. diff in quinolone prophylaxis arms. So if we look at the randomized controlled trials in this table, they have looked at rates of C. diff and both found no difference. But I do note that one study by Alexander et al. Did find a numerically lower rate of quinolone prophylaxis, of C. diff in the quinolone prophylaxis arm. So if we look at the observational studies, they have also got reported very variable differences. So we have a study by Maurer et al., which is a single center study in adult transplant recipients, which found actually reduced C. diff in the quinolone prophylaxis arm. And then we also have a study in pediatric patients by Wolf et al., which also found less C. diff in the quinolone prophylaxis arm than the no prophylaxis arm. And I will also say that there was a third arm in this study that was prophylaxis, but not with quinolones. And they found that the C. diff rates were actually very similar to no prophylaxis. So maybe there is something to do with quinolones that reduces the risk here. Perhaps maybe that they exert their activity on mainly aerobic bacteria rather than anaerobes. But then again, we do have some observational studies that again have observed no difference. But notably, we don't really have studies to show that there's an increased risk of C. diff in this particular patient cohort. And I guess there could be a few reasons or a few things at play here. So one, we do actually have two studies, one by Wolf and Alexander et al., which looked at impact on other antimicrobial use in patients who received fluoroquinolones. And they found that there was statistically significant reductions in use of other antimicrobials. And this might explain what I alluded to earlier, that these other empiric antimicrobials like piptaz, cefepime, etc., might impact the microbiome more and predispose patients to C. diff more so than fluoroquinolones. But the counter argument, I guess, for that is we're ushering in this new era of limiting our empiric antimicrobial use after the publication of studies like How Long. So I wonder if in these studies that these other antimicrobials were perhaps used for longer than they needed to be. And if a study was completed now, would these significant reductions be found or not? Probably remains a question to be answered. So what about the impact on the microbiome? So we know that this is a fairly emerging area of research and has become more topical in the hematology oncology space following studies that have observed that alterations in the microbiome have impacts on the outcome of patients who undergo stem cell transplants, receive CAR T therapy, or on checkpoint inhibitors. Unsurprisingly, data in the neutropenic fever space is, the quinolone prophylaxis space, is really limited. We do have one study by Tor et al., which found that quinolone prophylaxis reduced proteobacterial domination in the gut, which was actually associated with decreased gram-negative bloodstream infections. Another study found that in patients who were colonized with fluoroquinolone-resistant Enterobacterales pre-transplant, that there was reduced efficacy of quinolone prophylaxis in this group and increased risk of these organisms actually causing bloodstream infection. And then lastly, we have one more study which looked at, the impact of longer-term fluoroquinolone prophylaxis used across multiple cycles on the gut microbiome, which found that there was persistent colonization with resistant bacteria in patients who patients who received fluoroquinolone prophylaxis for that extended period of time. However, this study didn't really look at the clinical impact of these microbiome changes. So then we've got probably perhaps the biggest part of the discussion in terms of the con debate is antimicrobial resistance, which is probably the biggest concern. Many studies have been done and a lot have shown that fluoroquinolone prophylaxis does drive AMR, but I should say not all studies have too. So in one study in adult transplant recipients who were given fluoroquinolone prophylaxis, this study found that 31% of patients who were colonized with ESBL pre-transplant actually developed ESBL bloodstream infection, and genotypic testing confirmed that it was the same as the colonizing organism in all of those patients. And this is compared to only 0.4% of those who were not colonized going on to develop bloodstream infection. So this suggests that fluoroquinolone prophylaxis may facilitate the predominance of multi-drug resistant organisms in the gut, which can then go on to cause infection. And this is essentially consistent with the findings of the microbiome studies that I talked about earlier. So another study looked at a cohort at a single institution pre and post the de-implementation of fluoroquinolone prophylaxis, and they found that in patients who received therapy during the fluoroquinolone prophylaxis era, there was a higher risk of infection with drug-resistant Pseudomonas in these patients. While another study conducted across 12 countries also found an association between fluoroquinolone prophylaxis use and MDR Pseudomonas. But in terms of the effect on AMR and outcomes, this is probably less well studied. There is one study I was able to find that was conducted in Brazil that found after stopping fluoroquinolone prophylaxis, overall bloodstream infections increased, but notably multi-drug resistant bloodstream infections decreased, and the overall impact on mortality was actually a reduction as a result of this. So I think this really speaks volumes about the fact that not all BSI is equal, and multi-drug resistant BSI may confer much worse outcomes than just BSI due to more susceptible organisms. And then on top of these studies, we have multiple other studies that have shown that in institutions that de-implemented fluoroquinolone prophylaxis, there was a reduction in multi-drug resistant organism bloodstream infection, but these studies didn't find changes in mortality, unlike the previous study in Brazil that I just talked about. So where does that leave us after this sort of whirlwind run through the evidence? I think ultimately, there are benefits to using prophylaxis, and that is mainly in reducing bloodstream infection. And I think the impact of this is quite well defined, but it always must be weighed against the cons. And I think the main con is antimicrobial resistance. And there are certainly signals that prophylaxis with quinolones contributes to AMR, but this is inherently a difficult area to study and quantify. So that really leaves us with having to assess individual risk benefits for patients. And this might include looking at the disease, whether or not the patient has high-risk disease, such as acute leukemias, or they're receiving allo transplant. Is it de novo disease, or is it relapse or refractory leukemia? These are all considerations. Then there's treatment-related considerations. So how intense is the chemo? How much mucositis are we anticipating? What is the depth and duration of neutropenia that we would expect? And in patients who are undergoing stem cell transplant, we can further stratify them as well. We know that those that receive transplants with an umbilical cord stem cell source are at high risk of infection, and so are those who undergo haploidentical transplants. And then there's colonization status, which I've just some of the studies I've discussed earlier seems to be a quite important determinant of outcomes in terms of bloodstream infection. The setting of the patient matters. So if a patient is an outpatient and doesn't have ready access to a hospital, they may benefit from prophylaxis. Local epidemiology and baseline resistance, of course, would also come into play. Patient preference and patient experience is another consideration, as well as individual risk factors for adverse events such as tendinitis or aortopathy or some of the others. If somebody had a previous tendinitis to a quinolone, you may consider not using it. And then lastly, your hospital infrastructure should be a consideration too, in the ability for your hospital system to prevent infection and manage sepsis or septic shock. So with all that, I thought we would revisit our case again, but this time I'm going to let you guys...
Can we take out the 25% resistance, just take that off, and just get people to vote on just the clinical case without the background resistance rate. So yeah. For those online, we'll just ignore that. So this is really what we're trying to get you to think about is, if you had a really, really, really high risk patient, ignoring the epidemiological risk, what would you do?
Oh, it's already got results. How do I...
Oh, is that
this?
It's
going to make this open-ended one, yeah. So people
okay, cool.
In, but
yeah, no, that's fine.
I don't think it's letting people. Can people actually answer this, or is it closed? So I'm happy for you to answer yes or no, or you can describe some other considerations that are important to you.
Paradoxically, and Michelle might want to comment on this, with the move to, and maybe we can open up the discussion just after this, but with a move to ambulatory models of care for leukemia, there is pressure on using neutropenic prophylaxis for patients at home, but we can discuss that in a second. Maybe we'll stop sharing, and we can use some of those as discussion points about exactly what kind of past severe infections you would have. Thanks, Nick. That was a brilliant presentation. So opening up for discussion now, just taking some of those points one by one. I mean, one of the things for antimicrobial stewardship, because of the low resistogenic profile of ciprofloxacin, do people that believe and the more common use, well, the other challenge looking at the literature is that there's widespread use of levofloxacin in clinical guidelines, and ciprofloxacin is used less often. In Europe and Australia, quinolones are not endorsed for the use of this indication. Josh Wolf, I think you're online. Welcome. I don't know what time it is for you over in the States, but do you want to comment what your routine practice is at St Jude's?
I'd prefer not if that's an option, but given that you put me on the spot, yeah. So we do use
It's just
routine.
interesting to hear what your practices are, I think.
We do use routine quinolone prophylaxis in high-risk patients during periods of prolonged neutropenia, typically AML or ALL in intensive induction therapy, or relapsed ALL getting therapy. In patients who have severe mucositis or have received high-dose RSC, cytarabine, we actually add vancomycin for VGS prophylaxis. And that's a bit more controversial even at St Jude. But if you look at any of the AML quinolone studies, most of the breakthrough infections are gram-positive infections, and in some cases they've been life-threatening, and so that's been our approach. And one of my jobs has been to try to push back against prophylaxis by trying to evaluate the risks. And most of my publications over the past, I guess, a couple of years before COVID, were focused on trying to evaluate that. And so far, I haven't come up with anything that's really compelling to avoid it. We looked for, as Nick, thanks for bringing those up, we looked at neuropathy, we looked at C. diff, we've even looked at resistance after completing a course of fluoroquinolone prophylaxis. So in kids with ALL, they get it during induction, and then for the 2 years after induction, they're still at risk of infections, although it's a lower density of infections. And we looked to see whether kids who'd had quinolone prophylaxis versus no prophylaxis were more likely to get resistant infections in those subsequent phases of therapy, and found that they weren't, suggesting that risk of resistant infection is predominantly for breakthrough infection. And that, again, may be related to the heavy exposure to other antibiotics in patients who don't get quinolones because of fever or infections. So I think there's a lot more research needed in this space, and hopefully people will do it.
Fantastic, Josh. I think it's all important to reflect on regional practices. I noticed Julian Lindsay's also online, who's up in Seattle. What's the practice in the adult population that you're looking after?
Hi, I'm not going to put my camera on because it's quite late at night and I'm not dressed well enough to put my camera on. And it's very hot up here. So it's essentially the same as Josh explained, the widespread use of levo. There's not as much pushback. And as you mentioned, the ambulatory care is a big issue. Even very high-risk patients aren't inpatient for the entire duration of their neutropenia. And so allos, AMLs, even the CAR Ts are getting levo prophylaxis. And yeah, it's the practice here. It's very hard to go against the grain. With more microbiome studies, I think there are avenues to look at studies to try and reduce that usage. And I guess one thing that's always brought up that I don't think we covered, which is, you alluded to it, Nick, is that when you have fluoroquinolone prophylaxis and you're reducing febrile neutropenia in about 30% of those patients, that means that 30% of those patients will only receive fluoroquinolones. If you don't use fluoroquinolone prophylaxis, you're talking, especially in an allo or an AML, like 90 to 100% of those patients requiring at some stage broad spectrum empiric antibiotics. And so I think a lot of discussion also needs to be to discuss the timelines. How much time are we saving away from broad spectrum antibiotics? Because it's very easy to say fluoroquinolone prophylaxis or nothing, sort of just like alluding to that they're never on any broad spectrum antibiotics, but you're really just having a small period of time of nothing before going on an empiric antibiotic if you are an allo or an AML patient.
Thanks, Julian. Monica, do you want to comment on, you've obviously been involved in some of the European guideline development. What's your thoughts?
Yeah, thanks, Kaz. Well, I was involved in the ESOL guideline meetings, and I guess there was very widespread concern about rates of gram-negative resistance in many of the European centres, and that really prompted a kind of watering down of their enthusiasm for fluoroquinolone prophylaxis, because I do think if you look at centres that have heavy use of fluoroquinolone prophylaxis, and it's hard to know, whether it's cause or effect, but there is generally more resistance, gram negatives. And we know it's just not fluoroquinolone resistant gram negatives because of the way resistance travels in packs. The genetic material kind of moves together, and you might end up having a more carbapenem resistance or more ESBL organisms as well. So I guess there's that consideration, and that's why the Europeans kind of watered down their recommendations about prophylaxis, although didn't completely reject it, and went for the approach of very aggressive upfront treatment of febrile neutropenia and early cessation. So they kind of linked moving away from prophylaxis to really shortening their course of empiric therapy. So I guess, it brings up what Julian was saying about looking at the patient's whole course, not only prophylaxis in isolation. So it's a really interesting discussion. And I just don't know that we really got enough clear evidence one way or the other at present.
So I've noticed some of our Singaporean colleagues are online. Jasmine, did you want to comment on what's happening in your organisation?
Hey, hi. Yeah, we're using universal fluoroquinolone prophylaxis, probably driven by the NEJM studies. That practice has been deeply entrenched for the longest time, but increasingly there is an increasing awareness that there are microbiome changes in the patients, and they could have many downstream implications. Our resistance rates are relatively high compared to Australia. So then there is some form of move or stirring to shift towards a no fluoroquinolone prophylaxis. But I guess the question is, how do we design the transitions from a universal fluoroquinolone prophylaxis to no fluoroquinolone prophylaxis, and how do we prepare the system to manage the complications thereafter and the overall antibiotic consumption? I think there's some work to be done there, and we are aware of it. I'm slowly moving towards that. Yeah, over.
Thanks, Jasmine. That's helpful. Yes, so generally speaking, what we're seeing is a shift in epidemiology of the patient and shift in exposure to overall antimicrobials. So we need to think of the whole course of their disease instead of just this particular thing. Just throwing across to the RCH, Yara and I think Alison are both on. What's your current thoughts about what's happening over at the kids?
Thanks, Cass. I feel I'm a little underqualified with Gab not on the
I
line.
can't see our esteemed leader, Gab, here. So
Yeah.
Sorry.
Oh, there
you are, Gab.
Over to you. Gab, over to you.
I've just been in meetings and I've only just joined.
It's just understanding what the thoughts and practices around fluoroquinolone prophylaxis are over at the kids at the moment, currently.
Yeah, so traditionally we haven't used it, and then with the introduction of a new ALL protocol that is certainly more intensive than what we're used to in the induction phase. Part of that, as part of the protocol, kind of like mandated within the protocol approach, was levofloxacin prophylaxis, which has been used here. And look, I think got some work to do to understand the impact of that. Anecdotally, we haven't seen resistance and breakthroughs really, but there hasn't been a formal, there just really hasn't been the resources for formal audit and review of that, which will happen at some stage. I've got mixed feelings about it. I've missed the presentation. I think as a general rule, if patients are staying within the hospital building waiting for their fever to start, you've probably covered all this, that it doesn't make sense to me to have someone on prophylaxis. If you've got a regional patient that's going to be in a high-risk phase that needs to get home, there might be individual situations where prophylaxis may work, and we've used it on a case-by-case basis in the past.
I think from
probably where I'm sitting, and it seems to be on the fence.
I think all the guidelines definitely discuss the fact that you need to take a risk-based approach, and we've never had it as a routine practice here. But there are cases, particularly patients that have had a bona fide sepsis episode and have got more, you know, continue on with chemo, to think about that group, particularly elderly patients. I know there's a few minutes left, but I did want to throw to Michelle Yong. We're involved in a large MRFF clinical trial where we'll be working to develop up an ambulatory model of to manage patients having AML, venetoclax, azacitidine in the home. So Michelle, your thoughts?
Yeah, I think it's a great talk, Nicole. I think it's important to also recognise different models of care where we're moving with new different AMLs and new treatments, particularly those which are probably considered less intensive. So how to manage febrile neutropenia in the ambulatory setting is what I'm working on. There is some, like Kaz said, some push to do prophylaxis, and we've sort of landed on a risk-based preemptive fever management rather than true prophylaxis. My other thoughts when listening to your talk is whether there's been any work with individual risk. Seems like we can't, it's very controversial, the two sort of different arms, and rather than secondary prophylaxis, is there any work on whether there is individual risk up front, genomic work or host immune work?
Not that we've come across, Michelle. It'll be interesting for the neutropenic fever guideline writing group to see whether there is anything there. I mean, I think all of us, and Gab and those of Ben who are online, those of us who've been doing some of the biomarkers for risk prediction. Ben, did you want to comment on, we've sort of always been interested in risk prediction for you know, bacterial, viral and fungal infections. Did you want to comment on, is there anything you've come across in your reading that'll be relevant here?
Thanks, guys. I mean, just in general, unfortunately, that space is just too immature to sort of implement into practice. I mean, even for what we've been doing, it sort of tells us, perhaps it hints at, you know, you could find signatures of future risk, but not well enough, certainly not large enough to say it's, you know, future risk for bacterial infection or future risk for gram-negative, to the point where you could say in this group needs prophylaxis, in that group, you know, no prophylaxis. So, I mean, eventually, of course, the hope is that you'll get to something like that, but probably not. I do have to run off, but I just wanted to make the point, I think Nicole sort of raised it as well, but my concern about the prophylaxis space has always been not just the problems with that particular myeloma study, which just as a comment, that there was actually a lot more febrile episodes that drove the primary outcome in that particular trial. But also, I think what we've been noticing is that people draw lots of expansion of inferences. So suddenly it's now being used as recommendations to be used, prophylaxis to be used for bispecific therapies, for example, when it was never studied in bispecific therapies. So suddenly it's now, oh, if it's good enough to use in AML, we should use it also in other types of therapies in hematology. So that's my concern, that there's always this sort of indication creep. But anyway, sorry I had to run off.
No, thanks, Ben. I think we'll finish up now, but I think all of you will agree that it was a brilliant presentation, Nick. Thank you so much. And also for Josh, who's been working with us, pulling some of this evidence together for this current opinion paper, Gab, that you should be very happy about.
I am looking forward to reading it.
Yes.
Thank you guys, Josh, Kaz, and Nick.
And thank you everyone for joining, and please distribute it widely once it's up onto the NCICT website. I think it's been a really comprehensive and terrific overview of the state of play. Have a good afternoon, everyone.